if you want to officially present today's lesson.
Yes, sure. Thank you very much, Prof. Good morning, good afternoon, everyone. Welcome to today's DCB Academy session on management of LDL in acute coronary syndrome patients, early or still earlier, by Dr. Filippo from Italy. Dr. Filippo, please, the podium is yours.
Thank you, Prof. Thank you, Sarah, for the introduction, and thanks to all of you. I'm glad to discuss with you about the management of low-density lipoprotein in patients with acute coronary syndrome, early or earlier still. Lowering LDL cholesterol is a major goal in patients with acute coronary syndrome. Indeed, nearly 15% of patients experience a recurrent cardiovascular event during the first year after hospital discharge, and the first 2 months represent the most vulnerable period. Since the publication of this landmark meta-analysis, published in 2005 by the Cholesterol Treatment Relative Collaborations, a clear-cut positive association between LDL levels and the risk of future adverse cardiovascular events has been clearly established. At the same time, the search for new lipid-lowering agents has led to development of new therapeutic options, and at the same time, randomized clinical trial demonstrated their safety and efficacy in reducing LDL levels and in improving clinical outcomes. Statins are the cornerstone of hypolipidemic therapy. They function by binding the hydroxymethylglutaryl coenzyme A reductase, a protein involved in the synthesis of cholesterol by the liver. So they function by binding the synthesis of cholesterol by the liver. And robust evidence demonstrated their safety and efficacy in the context of ACS. Specifically, the landmark MIRACLE study demonstrated the ability of statins compared to placebo to reduce major adverse cardiovascular events at 15 weeks, while the PROVIT trial demonstrated the superiority of high intensity versus low dose statins in improving 2-year clinical outcomes. Then ezetimibe works by inhibiting the Niemann-Pick C1-LEC1 protein, thereby reducing the absorption of cholesterol from the intestine. And when added to statin, ezetimibe demonstrated incremental reduction in LDL and has been associated with improved clinical outcomes. The landmark trial is represented by the IMPROVE trial, which enrolled nearly 18,000 patients with ACS and elevated LDL cholesterol despite high-intensity statin therapy. And at 7-year follow-up, the addiction of ezetimibe to simvastatin demonstrated a reduced incidence of major adverse cardiovascular events with an hazard ratio of 0.94. Then PCSK9 is a protein involved in the disruption of endocytic recycle of LDL receptor. So PCSK9 promotes the LDL receptor lysosomal degradation. This process inhibits the uptake by the liver of LDL cholesterol, promoting hypercholesterolemia. Therefore, blocking PCSK9 is a major target to improve dyslipidemia and the hypercholesterolemic state. Currently, there are 2 different strategies available to inhibit PCSK9. Alirocumab and evolocumab are fully human monoclonal antibodies that directly block the binding of PCSK9 to the LDL receptor. The major evidence of their use in ACS is represented by the Odyssey outcome trial, in which nearly 19,000 patients with ACS and LDL more than 70 milligram per deciliter, despite a maximal tolerated statin therapy, were randomized to evolocumab or placebo. And at 5-year follow-up, alirocumab led to a reduction of the composite endpoint of death from coronary artery disease, non-fatal myocardial infarction, fatal or non-fatal stroke, and hospitalization for a stable angina. The other strategy is represented by inclisiran, which is a small interfering RNA able to destroy the messenger RNA for PCSK9. The twice-yearly administration is a major advantage of inclisiran in order to improve patients' compliance to therapy. In Here on the top of the right part of the screen, you can see the Orion 3, which was a trial designed to assess the effect of long-term dosing of inclisiran in patients with coronary artery disease. And inclisiran demonstrated at 4-year follow-up a sustained reduction both in PCSK9 concentration by nearly 76% and LDL cholesterol reduction by nearly 50%. Then patient level pooled analysis of Orion 9, 10, and 11 included 3,600 patients with familial hypercholesterolemia and atherosclerotic cardiovascular disease. And at 18 months follow-up, inclisiran demonstrated a reduction of the major adverse cardiovascular events with an hazard ratio of 0.75. Finally, we have bempedoic acid, which acts by inhibiting the adenosine triphosphate citrate lyase, which is a protein implicated in the hepatic synthesis of cholesterol. And when added to statin, bempedoic acid demonstrated a reduction of LDL levels of nearly 18%. The landmark clear outcome trial, including 14,000 patients with ACS, demonstrated the ability of bempedoic acid compared to placebo to reduce the occurrence of MACE during a long-term follow-up with an hazard ratio of 0.87. So, what is the standard therapy to treat dyslipidemia during ACS? Current European Society of Cardiology guidelines recommend to reduce LDL levels below the threshold of 55 milligram per deciliter and to reduce by 50% from baseline value. Furthermore, this guideline recommend to use a stepwise approach with the onset of lipid-lowering therapy with high-intensity statin therapy in patients naive from lipid-lowering therapy during hospital admission, and eventually introduce ezetimibe or PCSK9 inhibitors only during 4-6 weeks follow-up in case of LDL levels more than 55 milligram per deciliter. So this approach is commonly known as the lower, the better approach. However, this strategy appears ineffective due to several reasons. First of all, the expected reduction in LDL cholesterol in response to pharmacological intervention is predictable based on baseline LDL value, ranging from 30% with moderate intensity statin to 50% with high intensity statin until 85% with PCSK9 inhibitors, in addition to high intensity statin and ezetimibe. So, for example, if we have a patient with ACS naive from lipid-lowering therapy and with a baseline value of 160 milligram per deciliter, the introduction of high-intensity statin therapy could reach a value of nearly 80 milligram per deciliter, far from our target of 55 milligram per deciliter. Second, recent real-world data suggests that suboptimal management of dyslipidemia is widespread, and that goals of cholesterol are achieved in only 30% of patients. The largest evidence was provided by the Da Vinci, which was a cross-sectional observational study conducted across 18 countries in Europe. This study included more than 2,000 patients and demonstrated that high-intensity statin therapy was used only in nearly 40% of patients in secondary prevention, and that goals were achieved in...
Filippo, excuse me. So for Da Vinci, when was it published and which are the years of enrollment, the year that they are considering, and which are the PIs for the study?
The PI was Ray. The study was conducted in 2017 and 2018 and was published in European Heart Journal in 2021.
Okay, so this is a picture of 8 and 7 years ago.
Yeah, exactly.
Okay.
Surely
okay,
the
thanks.
situation was improved in the last years.
Yeah, no, but this is important to contextualize it. Thank you. Thank you.
I agree with you. Thank you, Prof. Then a very interesting study is represented by the Fourier open label extension study, which included patients enrolled in the Fourier trial So patients with atherosclerotic cardiovascular disease and elevated LDL cholesterol randomized to evolocumab or placebo. At the end of the study, patients initially treated with placebo were transitioned to evolocumab, and of interest at 5-year follow-up, the upstream initiations of evolocumab provided incremental benefit in cardiovascular events. So there was, during 5-year follow-up, a higher rate of events in patients treated initially with placebo. In line, the very large SWIDAR study demonstrated that in ACS, early and sustained reduction of LDL cholesterol within the first 2 months was associated with a significantly lower rate of major adverse cardiovascular events at 5-year follow-up. So these findings suggest that the first 2 months represent the most vulnerable period associated with a higher occurrence of adverse events. So it's crucial to reduce early LDL cholesterol to improve long-term clinical outcomes. Based on this assumption, the lower the better approach has been replaced by the strike early and strike stroke approach. This paper, published by Giuseppe Musumeci and colleagues try to outline how strike early strike stroke approach consists.
Excuse me, I cannot see the reference below. Where was it published?
In 2023.
Where? Which journal? Cannot see it.
European Preventive Cardiology, if I remember well.
Okay.
So the strike early strike stroke approach consists in the upstream implementation of PCSK9 inhibitors in addition to statin and ezetimibe in patients with ACS, naive from lipid-lowering therapy, and with LDL values more than 140 milligram per deciliter, with routine evaluation at 30-day follow-up. Are there some evidence related to this approach? Yes. The EVOPAX was a randomized, double-blind, investigator-initiated trial involving 308 patients with ACS and elevated LDL values randomized to PCSK9 inhibitors or placebo. The primary endpoint was the LDL value lower than 70 milligram per deciliter at 8 weeks. And this study demonstrated that patients treated with PCSK9 reached the goal in nearly 96% of the cases, while patients treated with placebo only in 37% of cases. And from a clinical perspective, it's important to mention the FastNote registry, which was a study published in 2025 by Giuseppe Patti and colleagues. This trial included 500 ACS patients stratified into 3 groups. In red, you can see patients enrolled in the first phase when the LDL threshold was 70 milligram per deciliter. In yellow, patients enrolled in the mid phase when LDL values was below 55 milligram per deciliter, and in green, patients enrolled from the 2021 to the most recent period, in which high administration of PCSK9 was used in patients with ACS naive from lipid-lowering therapy and with LDL values more or equal than 150 milligram per deciliter. And the authors demonstrated that early administration of PCSK9 inhibitors during the hospital stay was associated with a higher achievement of LDL goal and was also associated with a lower occurrence of major adverse cardiovascular events at 1 year. So, in conclusion, early and sustained reduction of LDL cholesterol provides prognostic benefit in patients with acute coronary syndrome. The very recent strike early and strike stroke approach is effective in reducing LDL cholesterol compared to the lower the better approach and demonstrated promising results in lowering MACE. However, the ongoing EVOLVE-MI and AMUNSER trial are needed to clarify whether upstream initiation of PCSK9 inhibitors could improve clinical outcomes in patients with acute MI. Thanks for your attention.
Thank you, Filippo. Thank you also for respecting the timeline in such a big topic, which could lead to confusion. But I think that you were able to maintain the correct direction of the ship. So thank you for teaching us on what to do. Though I have to say that in real life, it can be more complex than this because there are many regulations, especially with the new drugs, that are expensive. So in some countries, there is a cap or there is a quite complex, we call it piano terapeutico, therapeutic plan, we could translate, which takes time and which has different rules and requirements before we can start new treatments. Until last year, when I was working in Italy, it was somehow difficult to prescribe, for example, a PCSK9 inhibitor in the hospital during the first hospitalization with ACS, despite some studies, also the one that you cited from Giuseppe Patti, are showing that there is a clear benefit. But of course, the interest of our administrators, I would say, is to save money. And again, these drugs are really, really, truly expensive. So yeah, so this is the only limitation. I don't know if you or anybody else would like to comment on this.
Yeah, I agree with you. Nowadays, these drugs are used in Italy just for clinical research. So there are in our center we participated to an Italian multi-center experience called AttiTarget, promoted by Professor Indolfi and Esposito. So we use a lot PCSK9 inhibitors, but only in this clinical context. And because, as you said, they are very, very expensive.
What's the alternative, though, if we're not gonna use them?
The alternative to PCSK9 inhibitors? Filippo.
There is bempedoic acid, but you can use it.
Bempedoic acid is you can use it instead of statins, so it's not potent. So
yeah, just 15%.
The other one is inclisiran.
Yeah, and just so for bempedoic acid, just if the gap between the baseline value and the girls is nearly 20%, unless they are unuseful and associated with some gastrointestinal complications. Inclisiran, yes, is a valuable alternative, but at least in our experience, when you switch from PCSK9 monoclonal antibodies to inclisiran, you have a rebound of LDL values. And this data was also confirmed by a recent German experience. So it's a matter of debate nowadays.
What do you mean, rebound? Okay, so you interrupt PCSK9, and how much time after do you usually start inclisiran?
Maybe one month later, but until 6 months, we have a 6-month follow-up. There is an increase in LDL values of nearly 20 to 30%.
And starting earlier? I mean, after 5 days from the last PCSK9 inhibitor injection?
I don't think that there is a difference. Maybe in this German experience, it was started earlier, but there was no difference because I don't know. Maybe inclisiran is not so fast in lowering LDL values.
Yeah. So this is a problem with inclisiran. So PCSK9 inhibitors are much faster. So we cannot achieve we can achieve a very good and effective reduction in LDL, but not immediately. So probably they are out of topic from today's lesson, I would say, if you need to be fast.
Yeah.
Thank you, Dr. Filippo. It was a very nice